And good afternoon, everybody. And we're just slightly late. My name is Justin Blake. We've got my colleague with us, Doug Richie, in California this afternoon. How's things, Doug?
Things are great in California, except it's raining today.
Okay. Well, we're like -1 in temperature here. So
Okay.
It's getting pretty. We're in the middle of winter. We had some snow yesterday, which was good. Makes things look a little bit more picturesque.
Good for you.
Certainly highlighted the thing. So, but yeah, everybody's wanting some warm weather now, especially with the way things are. Of course, interesting times in the States. Tom Brady to another Super Bowl final.
Wow, so you're a fan, I guess.
I'm a Bears fan, unfortunately.
Oh, are you? Okay, yeah, those were two very good games yesterday.
Yes.
And there's hope for us old guys.
You think?
Yeah.
Old guys. Well, he's hardly old, is he? What age is he?
Well, he's getting better with age.
Yeah. Better with age. Let me just sort that out. He's getting better with age. Yes, most certainly. So yeah, but no, certainly interesting times. I mean, you don't practice with patients anymore, Doug?
No, I retired from clinical practice 2 years ago, almost to the day.
Yes. Okay.
Allows me to devote more time to teaching and running my Richie Brace company and other endeavors. So it was a good thing.
Yes, and of course, more time to spend on the new book that's just come out.
Yes.
So we're going to talk a lot about that today, because I have made my way through about the first 4 or 5 chapters. But especially the midfoot. I think, well, of course, the foot is. I think the foot is still the misunderstood foot, to quote a colleague.
Yes, I would say that's still true today.
And there was a lot of information in there which is going to, I think, change the way that, well, certainly things, well, I hope, the way things are going to be taught. There's a lot more sort of scientific research to back up, especially in the midfoot, because a lot of the patient problems that I saw in the last number of years, midfoot was playing a huge part of it. And one of the interesting things was that there's more dorsiflexion in the midfoot than there is actually in the ankle joint.
Yeah, absolutely. A number of
why do we measure ankle equinus and get so caught up about it?
Yeah, that's a very good point. That's actually one of the points I made in the book.
Yeah, because I mean, ankle equinus, I think, is drummed into us that it's it's the most destructive, problem that affects foot function.
Oh yeah, I see it attributed today as the primary evil of the human foot is equinus.
Yes.
The most destructive mechanism affecting or causing foot dysfunction. Absolutely. Yeah. And yet we don't really have a way to measure true ankle equinus. So the diagnosis is elusive at best.
Elusive, to say the least. Yeah. And it goes into quite a lot of sort of debunking the sort of the unlocking and locking sort of theories in which is a good thing.
Yeah. Well, if I go back, to my own development and my own education, it was early on that I would hear my professors, including John Weed and Mert Root, use the word foot pronation and subtalar pronation interchangeably. Mm-hmm. And they would say, well, I observed this patient, their foot, da-da-da-da, and I would stop and say, when you say the foot, what joint are you talking about that's actually moving here? And they would often say, well, of course, the subtalar joint. And so, fundamental to a lot of Root's teachings and his proteges was interchangeably using the subtalar joint with the foot and attributing all motion of the foot to the subtalar joint. Mm-hmm. And so one of the early points of my book was showing all these elegant kinematic studies that show that the subtalar joint contributes less motion than at least 4 other joints in the foot. Even in the frontal plane, inversion, eversion, the subtalar joint ranks 4th in overall contribution. The talonavicular joint contributes more. The ankle joint contributes more. And so does the cuboid 5th metatarsal joint, believe it or not, contributes more frontal plane inversion, eversion than the subtalar joint. And yet today there are many people who think the subtalar joint is the keystone joint of the foot. It's the fundamental determiner of all foot function and foot pathology. And we're finding that, no, as you're alluding to, the midfoot joints are far more important.
There's quite a lot going on there.
Yeah, there is. And the trouble is the subtalar joint was a joint, at least in terms of rear foot angle, we could look at pretty easily in the clinic. But looking at these subtle movements in the midfoot is difficult in the, in the clinical setting. And so I think for years people just kind of overlooked it because they couldn't see it.
Yeah. And well, of course, well, no, we'll get onto orthotics and treatments later on. We'll stick with pathology. Because, and I mean, I hadn't been aware of the sort of this, well, certainly the rotations of the foot, and certainly again with Bolson molar and all the lateral column, because again the lateral column again is sort of tends to be ignored,
right,
on the side of the foot. It's all about hypermobility and first metatarsal and first MPJ, hallux valgus, and hallux limitus rigidus. But of course, the lateral side of the foot has a lot of control over, in terms of the function.
Yeah, I go into that in the book. We segmented the foot. Now in the 70s, Root and Weed particularly segmented the foot into the forefoot and the rear foot. And I'll be honest with you, I rarely heard terms like lateral column, medial column in my education. The orthopedic surgeons started using those terms, and pretty much we accepted them in the surgical community. We talked about lateral column lengthening procedure, so the so-called Evans osteotomy, and medial column arthrodesis, and these columns I didn't really even understand. I had to go back and kind of read about it, and then later I discovered this fellow named McConnell who segmented the foot vertically, and we really kind of discovered later that guys like Vern Inman and others segmented the foot vertically. In other words, they looked at the tibia, the fibula, and the talus as one unit, and then all of the bones below it in the vertical level as the other segment. And to be honest with you, that's the more accurate way to do it.
Yeah, they didn't include the talus within the foot.
Correct.
It was part of the lower leg and ankle.
Yeah.
But the talus, of course, is you sort of with the control and the alignment and the position of the talus. I mean, do you think that's a lot of underlying cause into the with an anterior sort of shift of the talus in the ankle joint and a whole knock-on sort of sequelae through the foot? If you say it had a common ankle sprain.
No, I think the critical movement is all those bones under the talus. I don't think that's a big debate today, whether this tibio-talar unit directs motion of the foot bones or whether the foot bones direct motion retrograde into the tibia and talus, or even in bigger terms, whether the proximal part of our lower extremity, the hip, drives the foot or the foot drives the hip. And the research today is still somewhat equivocal on that. There's evidence that both drive shaft mechanisms are important, but I think the talus is really a passive bone, and it's directed more. The talus itself is directed by the tibia. There's no question. The tibia is the longer lever arm. The talus is firmly housed in the ankle mortise. It does have freedom of movement, but it's this massive tibia with a weight-bearing body above that drives the talus. But it's the response of the bones under the talus that ultimately determines stability and in my mind, the development of pathology. It's all those little bones that are connected beneath and how they respond and perform during dynamic gait.
And of course, everybody's individual, so they will perform differently. And you also in the book sort of debunk the sort of thoughts of axes.
Yeah, I just think I'm amazed at how, and even the younger podiatrists are just fixated on this fact that joints have axes, and more importantly, that people have axes. You know, I have a patient who has a deviated axis, and I kind of make a joke. I say, I've done a lot of surgery on the subtalar joint. I've gone in there, and you know something? I have never seen an axis.
Is that all Kevin Kirby's fault?
No, not at all. I mean, the axes, I mean, Hicks started the axes thing, and I'm a big fan of Hicks and studied Hicks and did I felt a really important research project validating Hicks' observation of the first ray. But I just think we have to put it in the right context, that's all. And there's great relevance, and I talk about joint axes in my book quite a bit, but I just think we have to step back and realize, an axis is merely the result of motion of the foot and not vice versa.
Yeah, no, it is an easier way to understand in terms of sort of planes and positions, and the sort of the seesaw analogy of the balance of the inverters and the everters.
Sure.
It's an easy way to visualize things. Well, I find it is.
Yeah, and because
we did change more into the more the mechanics side of things, away from the theoretical.
Yeah, I think what to me what's missing, at least here in the United States, with educating our podiatry students, is modernizing or bringing them up to speed with all of the kinematic studies that have been done in the last 20 years. You know, moving beyond what Root and Weed and Inman and Wright taught, and also bringing them up to speed with muscle moment arms and muscle function, and then realizing that all of that is controlled by the sensory motor system. And in spite of saying a patient has, quote, a deviated axis, that has absolutely no relevance until the body starts moving and it's regulated by higher neurologic centers. These axes go completely out the window when you start superimposing sensory motor control. And that's really the ultimate determiner of how we function.
Mm-hmm. Yeah, it's all related into the neural sort of system.
Yeah.
And of course, the way the sort of signals are sort of transmitted, and again, sort of previous history of injury or other sort of intrinsic, extrinsic factors. And I wasn't sort of familiar, because I posted earlier on today about the twisted plate theory. Which has come up with an Irish guy. He was born about an hour away from here up the road, Michael McConnell, in Cork, the anatomist, in 1944, the twisted plate theory. And I mean, I'd never heard it described as that. And it was interesting because I can't remember at some course one time we were talking about helping with plantar fascia, and it was, evert the foot, the forefoot, take the tension off the plantar fascia. And obviously that relates back to the work he was doing in the 1940s.
Right, no question. That came to light for me. One of the most elegant articles I've ever read, published at least in a medical journal, was written by Serafian, and in the early 80s in Foot and Ankle International, and he describes the loading and unloading of the plantar aponeurosis, and he shows in drawings the twisting of the forefoot on the rear foot, and he briefly mentions McConnell and references that article from 1945. But he goes in great detail to describe this configuration of the foot where the rear foot bones are compressed vertically or horizontally, or vertically, and the forefoot bones are compressed horizontally, and they're twisted on each other. And there's a direct relationship between twisting and untwisting and the tension in the plantar aponeurosis. And I thought that was one of the most brilliant explanations of how the arch of the foot behaves, how the tension in the plantar fascia behaves. And he even shows how the windlass mechanism comes into play with that. I think he became a bigger fan of McConnell after that article, because in 2 subsequent editions of Serafian's textbook of the anatomy of the foot and ankle, he began going into more detail and citing McConnell more frequently. And his latest edition, McConnell is mentioned extensively in the initial chapter on the mechanics of the foot. And Serafian becomes a great fan of his. And if Serafian's a fan of his, I'm a fan of his, because I think that textbook of anatomy from Serafian is the #1 book that all podiatrists should read and become well versed in clinical practice, let alone any foot and ankle surgeon. That is, to me, the finest biomechanics text of the human foot that the student could access.
Okay. And is it used at the moment?
No, it's really not. I run into podiatrists when I lecture here in the States and mention Serafian, and most of them don't have it in their library. I mean, they're aware of it, but they haven't purchased it, let alone read it.
Yeah. And do you think that there's more, from somebody outside of you, do you think there's more now understanding of biomechanics, but there's less biomechanics used by podiatrists in the States because it is more surgical based?
No question. No question.
So is there dumbing down of the biomechanics? Because you do mention, I mean, I think, and I was lucky enough to be qualified in the early 90s and was through that period in the 90s in the UK with Howard Dannenberg and Bolson Muller and those sort of papers that were then sort of like a great age of biomechanics. Have things stalled a bit?
Well, I don't think they've stalled. I don't think they've stalled anywhere but in the podiatric profession, particularly in the States. It's not just stalled, it's derailed.
And that's because it's surgery.
Ironically, it's because of surgery, and yet because of surgery, biomechanics should be emphasized more than ever. I mean, it just baffles me how a podiatric surgical resident, who's really a student, can be allowed to go in the operating room and assist or even participate in a flat foot surgery reconstruction when they haven't been properly schooled in biomechanics, let alone in evaluating the pathomechanics of the flat foot deformity. I challenge any podiatric resident in the country to really describe the flat foot and the way it disrupts the kinematics and function of the human foot. I just don't think they could do it because they haven't been properly schooled. Yes.
And is that just, is there more just a rush to more surgical practice then, or is that just because because we touched on that, I can't with who is it just because more people want a quick fix rather than a longer term?
Well, I think, at least for me, I went to the California College of Podiatric Medicine in the late 70s, graduated in 81 or 80. There was already almost a rivalry between 2 departments at that school. There was the surgery department and there was the biomechanics department. And believe it or not, in the late 70s, the biomechanics department was the enviable department. It was who we all strive to be like. I mean, our heroes were in that department. The surgeons, these guys were good guys and they were doing surgery, but it wasn't as exciting as what the biomechanists were doing, particularly with sports medicine and the evolution of the running revolution, which was taking off here in the late 70s. But gradually, the surgeons became the darlings of podiatric education. And sadly, because they were sort of rivals, they used to make fun of each other. The surgeons basically said the biomechanists, all they did was make plastic shovels to go inside of shoes. And all these plastic shovels were good for was a doorstop. I used to hear that frequently, from the surgeons. And sadly, because they were rivals, and because one department gained more prestige than the other, they kind of never merged and shared insights and realized the 2 were codependent on each other. And at least in the podiatry community, our premier conference in foot and ankle surgery is the American College of Foot and Ankle Surgeons, and it's the largest meeting in the country here. It's the largest academic meeting in the country, and it has no specific session and no specific lecture on biomechanics. It is 3 days of surgical lectures, and with criticism from me and others, they quickly defend themselves and say, "Oh, we integrate biomechanics into every lecture we give," and yet, having sat in those lectures, there's no biomechanics. It's all technique.
And again, is that the push because of insurance and because you can cut it and make it straight and get an outcome and you can measure it and bill and also bill for it?
I don't think it's insurance driven. I think it's glamour driven.
Okay.
I think these guys, I think it's more glamorous to put on a hood and a mask and goggles and go in there and use these high-tech tools and fix a foot than it is to put plaster around a foot and make a foot orthotic. I mean, let's face it, for a high school student who's considering a career in podiatry and they see those images, that's pretty exciting to them.
Mm-hmm. Yeah. And so do you think there's more of a rush now just straight to surgery then rather than giving any other options? Yeah.
Well, it's interesting because I still lecture at the school and I talk to students, and you ask them, why did you choose podiatry? What brought you here? How do you see yourself in 6-7 years when you get done with all this and finish your residency? And most of them say, I was intrigued and attracted to come here because of surgery. I mean, I saw those pictures. I was told that I would be able to assist in surgery by the time I'm in my 3rd year at school. And
do you think it's seen as an easier route then than straight orthopedics, or? Say
that again.
Is it a sort of seen as an easier route to surgery than straight orthopedics, or like say to be a hip surgeon rather, or?
I don't know if they see it as a. I think there is an economic standpoint, to go back to your first question. I think they somehow think they are going to get paid more, that a surgeon makes more money, and I think there was truth to that 20 years ago. It's not true today. Surgical fees have dropped by 50% over the last 20 years. Yeah. And what's interesting is what most of these young students don't realize is that when they get into their residency, and certainly when they get out, the majority of the surgery they're going to be doing is limb salvage. It isn't.
Well, it isn't popped into my head. I mean, yeah, you're young dynamic runners, any sort of sports orientated guys, ski stuff, ballet dancers. I mean, they're a long way off wanting any sort of major foot surgery if they're at a certain stage of the career. I mean, they're going to be avoiding it if all possible.
Yeah, and
if you can't fix it, if your only arrow in the bow is surgery, and rather than dynamic rehabilitation, foot realignment, and manual therapies and orthoses and bracing, then if you only got surgery, then they're not going to be, they're.
Well, I wrote a blog or I posted something a year ago that I got criticized by a lot of my colleagues here. And I said, quite frankly, when a resident finishes his residency in podiatric surgery and goes into practice, if I were a runner with heel pain, I would choose to go to just about any other specialist than a young podiatrist. Because I know I've trained podiatric residents, and they don't understand plantar heel pain, let alone know how to treat it. There are many other specialties that are better schooled, sadly. I mean, it's a sad statement, but it's just true.
Okay. And that's just more towards because of the surgery. Yeah. And okay, because it was seen just as less glamorous.
Yeah, well, we have there's a big political initiative going on in our profession here in the States right now, where the number of biomechanical exams that a resident has to perform during their 3 years of postgraduate training is going to be reduced from 75 exams to 50 exams over a 3-year period.
Okay.
So that means in each year, they only do 12 biomechanical exams, which means one a month.
Okay.
One a month. Okay.
Yeah.
And so there's all this outrage. Actually, it's good to see a lot of outrage among the general profession here, like, hey, you can't reduce that more. You actually need to emphasize it more. But the reason for proposing this change is that we don't want to burden these poor residents with meaningless biomechanical exams when they really need to be in the operating room more.
It's yeah, but so looking back in the book again, and any of the things that have influenced especially in the forefoot and the midfoot. I mean, yeah, as you say, unless you've got a really good understanding of that, surely that influences surgical technique and how that's going to progress. So you think the orthopods are ahead then? I mean, because and who's doing all the foot treatments then?
Yeah, well, the specialty orthopods, the foot and ankle fellows, are definitely ahead, and they're publishing much better research in foot and ankle biomechanics than podiatrists are, for sure. And I think during their training are probably getting indirectly better biomechanics, which they're applying to surgery, by the way, much better than our podiatric residents. For example, I went to the IFAB meeting that happened to be in New York City 2 years ago, might have been 3 years ago. And that is now a very sophisticated biomechanics conference for foot and ankle. But interestingly, it was in New York 3 years ago, and a full day was devoted to research on total ankle arthroplasty, total ankle joint replacement, as well as the emergence of weight-bearing CT imaging of the foot related to flat foot deformity. And a lot of the papers were presented by orthopedic surgeons who were out of the Hospital for Special Surgery, which is in New York City and is arguably the finest orthopedic hospital in the world. But to see the biomechanical research they were performing that had direct relevance to surgery, but it was really true biomechanics, it was spectacular. It was mind-boggling. And I wrote a blog about it afterward. I said, I looked around the room and I counted 3 podiatrists in the room at that conference. Here in the middle of New York City, where there might be, in the state of New York, almost 10,000 practicing podiatrists. I mean, where were they? Yeah.
Brushing up on their surgery.
Yeah.
They didn't realize there was that quite a split.
Yeah.
And are all the courses dictated by the content, or each university, California and Barry, or New York School? I mean, do they have different syllabus?
Yes, they have different syllabus. But I would say overall, the number of units devoted, the number of hours devoted through the 4-year curriculum, in the end, is relatively similar. Some schools have more emphasis than others. But the bottom line is the number of total hours is less than half it was when I was a student, in trade-off for courses that are more in line with allopathic medical schools, such as psychiatry, public health, research and statistics, which I can't say that some of those subjects aren't important, but they have replaced biomechanics. Because our argument was, if we can mirror allopathic medical schools, we should really get an MD degree when we finish, not have this silly DPM degree.
And is that what they're pushing for? Yes.
Oh yeah, they pushed for that. That was supposed to happen in 2012, where we would make this change, which was made, and then we would go to various governmental agencies and regulatory agencies and say, now we've achieved what's called parity. And it didn't get us anything. Well, we haven't been recognized in many states as equivalent foot as true physician and surgeons. We still have our distinct degree.
Yeah.
And as a result, we surrendered a lot of our unique training in biomechanics, tried to mirror allopathic medicine, but it, in my mind, didn't get us anywhere. I mean, maybe that's coming down the line, but I haven't seen it.
Okay. Yeah, we've similar things on this side. But of course, you're pretty familiar. You're you're a regular visitor to Europe and the UK.
Yes, yes. But what I wanted to extrapolate on now. Here's why all this is important. Forgetting all the political things and so forth, is the first chapter of pathomechanics in my book is the first ray, and to me, that's a great example of where this whole understanding of biomechanics and lack of understanding has gone haywire. There's a movement afoot here in the States to perform bunion surgery that absolutely violates the true understanding of the axis of the first ray and the true pathomechanics of how we get a bunion. And it was promoted by a group of podiatrists here who actually said there's no evidence of how the first ray moves in the human foot, and that in their mind it moves this way, even though they didn't do any kinematic studies. And now we're going to tell you how a bunion happens and how we need to correct it. And to my absolute amazement, it's become a groundswell here of a complete change in bunionectomy surgery in the United States, based on a total lack of understanding of how we get bunions.
And what new procedures are they? What are they calling their new procedure?
Well, it's called a triplane lapidus procedure, but it's where the surgeon goes to the first metatarsomedial cuneiform joint, also known as the first TMT joint, and they rotate it into inversion to correct the bunion. Now, we know that the pathomechanics of hallux valgus is excessive dorsiflexion and inversion of the first ray. Why would you twist that bone at that joint into further inversion? Why would you do that? Are they getting,
well, is it stabilizing things more then, or is it?
The theory was that it would, but the actual anybody who reads studies of the kinematics of that joint and studies of the first ray, and more importantly, studies of the pathomechanics of bunions, knows that the best remedy is to evert the first ray, particularly at the first metatarsomedial cuneiform joint. Happily, there's some research being published right now to verify that. And this is really going back and verifying what Hicks said in the early 50s. And then I was part of a study that with Mert Root and John Weed, where we verified Hicks' work on the axis of the first ray. But my point here is that without understanding true biomechanics, how can you develop new surgical procedures? How can you validate them? It's just absurd. And I've been a big critic of that, not from any financial reward or anything, just from the purity of the academics that I devoted a great deal of time to early in my career.
So they're just disregarding sort of things, but why is there a groundswell with it? If we say they think they're getting better outcomes now, or is it just a trend that's sort of happening?
Well, I think they're getting better outcomes just because they're paying attention also to other aspects. And the lapidus procedure is a powerful tool to correct a bunion.
But of course, you're starting to correct proximally at the navicular as well. Then, I mean, you're getting into all sorts of.
Yeah, well, see, that's the key, Justin, is that there is frontal plane deformity in hallux valgus patients, but it's right there. It's at the talonavicular joint. And that's where the excessive pronation, so-called, of the medial column occurs. There's no question, but it's not at the first TMT joint. It's proximally at the talonavicular joint.
Yeah, because some of those active CTs would be really interesting to sort of look at if anybody's ever actually seen, because again, I think this was the mechanics way we were taught things about levers and forces, and it all seems very structured. And then when you actually see a foot under a fluoroscope, under X-ray fluoroscope, especially if anybody wants to look, there's a really good video on the hypocure, and we'll get onto it in a minute, website where they show the foot. And I mean, the amount of movement in in the whole foot is just colossal.
Yeah. Well, I think weight-bearing CT, multiplanar imaging, right now is going to open up a complete revolution of the way we look at the foot. A complete.
You do reference the pin sort of research and things done, but I mean, you're not allowed to do that to people. So
But with weight-bearing CT, you can.
Yeah.
And I'm in a study right now at the Kent State School where we're looking at the first TMT joint in hallux valgus, and we're able to look at the actual rotation of that joint in 3 planes. It's mind-boggling how accurate it is and what we get to see. And so we're going to see a lot of verification of things we thought were true, and probably see a lot of contradiction. But it's an exciting time right now in biomechanics.
Well, it is. I mean, it's, of course, it's the morphology of the bone, which the planes which allow the movement.
Right.
So it's and again, you know, with stuff, and we referenced sort of Bob Kidd, and I think you've sort of seen the talk, and anybody missed out on it. I mean, Bob's a great guy with his with the research that he has done.
Right.
It's and especially that work on the lateral column and developing before the medial column, and it's so yeah, but it'll certainly sort of change the way we're going to look at the way sort of the things function. And the surgery is so the scanning will be even better, as you say, because it's reproducible, isn't it? Where a lot of the research before can't sort of visualize it.
Yeah, absolutely. I mean, we can, using 3D CT, we can calculate joint axes, but we can look at the interrelationship of the coupling and the movement of all these bones relative to each other, and specific to pathologies. We've already seen this in the adult acquired flat foot. I mean, those guys at the Hospital for Special Surgery have probably published maybe 10 papers now, just looking at adult acquired flat foot and these unique changes in the, as you say, the shape of these bones in the foot that are specific to adult acquired flat foot, and we don't see in healthy feet.
Sorry about that. You don't see the So is it the underlying morphology, or is it the way that the which came first? Is it the planes that allow, you know, you're just born with it, you're going to end up with it, you've got an axis is out here, and you've got planes that just, you're more a pancake type foot?
Well, we're beginning to see that. I mean, there is definite difference of morphology of the shape of the talus, for example, in adult acquired flat feet. The undersurface of the talus is angulated to a greater degree than, quote, healthy feet. Now, we don't know if that's adaptive or whether it was a predisposing factor, but we're definitely seeing difference in shapes of bones, not just in the position of joints, but the shape of the bone.
And then should we be going back to then sort of pediatric sort of screenings and you know, to identify? But again, you have that envelope of performance. Some people it affects them not at all, and some people are completely.
Well, you know, it's interesting, and I go into this a little bit in my book. Is this ongoing debate about the asymptomatic pediatric flat foot and whether it needs treatment? And
somebody contacted me last week on Facebook, just a friend of somebody in South Africa, and normal picture of the kid. I mean, the kid's 3 and he's got flat feet. You know, those flat feet.
Yeah. And as we know, the majority of those feet spontaneously improve, and the majority of those feet don't develop symptoms. But we have to recognize one thing, and all authorities on adult acquired flat foot agree that condition develops in a pre-existing flat foot. And we're seeing really almost an epidemic of so-called posterior tibial tendon dysfunction worldwide, adult acquired flat foot. And as we've studied it more and looked at the risk factors, the number one risk factor is pre-existing flat foot. So the bottom line is, which of those kids later in life is going to go on and suffer a catastrophic progressive collapse of their foot that is disabling without question? And I think 3D's imaging, weight-bearing CT, is beginning to give us some insight into that, where we might be able to predict this in certain children with flat feet.
Okay. and then intervene at that early stage?
Absolutely.
Okay.
Yeah. Same with bunions.
Mm-hmm.
I mean, I think there's certain children we can identify that are going to be at risk for developing hallux valgus, and I think there is some evidence, at least symptomatically, that foot orthotic intervention, but maybe muscular strengthening, maybe rehabilitation techniques might slow down the progression of hallux valgus.
Well, I think you've been quite an advocate, because I mean, you as you say, you've blogged and written and published for years, and I mean, there's a wealth of blogs on the Podiatry Today website, and they the changes that will sort of happen with the with orthoses. I mean, do you think those will be? How would you see that working?
Well, it's interesting. My latest blog, I made a big point, is I think one of the problems with biomechanics and teaching biomechanics in the United States is it's equated to foot orthotic therapy, and that biomechanics is foot orthotics.
Yeah.
And because foot orthotics have lost their luster, so to speak, worldwide to some degree, so has sadly biomechanics. And on the other hand,
I think that was just because they were dispensed like sort of Smarties without really, or was because the weren't doing what you wanted them to do.
Yeah, absolutely. And you might notice in my book, I never talk about foot orthotics. I don't think I mentioned the word foot orthotics in my entire book. When we started the POFOLA meeting, the Prescription Foot Orthotic Lab Association, that was an effort of foot orthotic labs, commercial interests in the United States, to somehow bring back interest in foot orthotic therapy and selfishly stimulate the volume of orders of foot orthotics to help save the industry.
Yeah.
And to do so, they rightly decided we need to legitimize foot orthotic therapy. We need to put some science behind it and make doctors feel good about this, that it really does work. Mm-hmm. And what's interesting, though, as it evolved, and I was very involved with it, I eventually became the scientific chair, the lectures at the POFOLA conference, more and more, didn't even discuss foot orthotics. It evolved into Irene Davis talking about, gait retraining and eventually barefoot running and, muscle function. And that's what it should do. Biomechanics is far more than just foot orthotic therapy. Yeah.
I mean, I was reading, you back even 10, 12 years ago, you were talking about, exercising flexor hallucis long extensors or long flexors of the foot for forefoot pathologies and toe problems. And again, that's something that just really isn't taught at an undergraduate level.
Yeah, and we're seeing all this interest in the intrinsic muscles of the foot and all this great work done in Australia with Luke Kelly and his lab. And it's exciting. And it brings to light that, muscle function and neurologic control over these muscles probably is where it's all going to be at. And in terms of preventing pathology, I think we're going to find a role for it. There's no question. I think even in bunions, I did bunion surgery for 38 years, and when I wrote the book, I discovered these papers showing pretty strong evidence that a group of patients with bunions have weakness of the abductor hallucis muscle. And I thought, nobody ever taught me that the abductor hallucis is weak in patients with bunions, let alone did anybody ever talk about strengthening it or finding out a way to make it work better so that certain people don't get bunions?
Yeah.
Never been taught.
No. So do you think those sort of short foot exercises and things are worthwhile? That Irene Davis sort of, she did it. They have the foot core paradigm in the British Journal of Medicine, BMJ.
Well, it's interesting. I saw Luke Kelly interviewed, I think, on Podiatry Arena, and they asked him that, okay, so you've put all this importance on the foot intrinsics. You must be a fan of all these short foot exercises. And he said, I don't think they're valuable. I don't think they're going to activate those muscles. I don't think it's appropriate. And they said, well, how are you? He said, you need to be much more dynamic with loading of the foot to activate the intrinsics, with almost with plyometric training and Single leg heel raises are going to activate the plantar intrinsics more than a short foot exercise, which was kind of interesting. I think the bottom line is we don't really know fully yet. But
fully yet. I mean, is that because we're just exercising larger muscle groups that have more control and more action rather than some little small muscle?
Well, I think so, and
of course, are they more there just through the proprioceptive feedback that they're giving rather than actual? I mean, a little bit like the lateral ankle ligaments. I mean, they're structurally they're not doing anything, but the proprioceptive feedback. And
I think structurally they are. I think structurally they are doing a lot, and I think when you look at digital deformities, which is amazing how little research, by the way, there's been done on how we get hammer toes. It's all speculative, and people still quote speculative articles written 30, 40 years ago about how do we get a hammer toe, and what's the difference between a claw toe and a hammer toe.
Yeah.
And we blame it on dysfunction of the plantar intrinsics, on the lumbricales versus the interossea, but there's no really good research on that. It's all speculative. But I think it's true. I think the intrinsics are directly involved with it. And I'm amazed that nobody's really focused time on that, because hammer toe surgery is probably done more frequently than any other kind of surgery on the human foot in the world.
Yeah. And especially, I mean, all the forefoot, that's where the proportion of forefoot ulcers and all the neuroma sort of related issues as well. And
sure. And here we go. You talk about the plantar intrinsics. Now, then we go to the diabetic foot, and we know that they get claw toes and they get high plantar pressures under the forefoot. And most podiatrists should know that high plantar pressures in the forefoot are directly due to loss of digital stability. And we use that term intrinsic minus foot, right, from diabetic neuropathy. So we've all along thought it was due to lack of function of the intrinsics, and it's true, but nobody's ever really researched that, let alone figured out a way to rehabilitate these muscles and make them work better.
Yeah. No, it is all linked, as you said. It's definitely, because when you talked earlier on about forefoot, rear foot, and lateral and medial and things, but again, it's everything connected together. I mean, it's a whole system, and I think that's when I started going to more and more treating with more manual therapies, I realized that it was so much more sort of interconnected rather than.
Yeah, and it's kind of funny. I've watched some of your videos, and nobody was a bigger skeptic of manual therapy than I was when I finished school, and even in my first 10 years of practice. My office, my first office in Seal Beach, was right next door to a chiropractor, and he would come over and tell me, "Oh, you're doing things all wrong. You just need to adjust the foot." And I said, "You got to be kidding me. Show me." And he actually showed me. He would come over and adjust some of my patients' feet, and I would see immediate results, improvement of range of motion, improvement of symptoms. And I thought maybe there is something to it. And as I studied the ankle sprain and got more and more involved, I realized these authorities on ankle sprain and rehabilitation have now totally jumped on joint mobilization and even manipulation as an essential part of restoration of function after an ankle sprain, and in great papers validating it. And it's all tied into the sensory motor system, though. You say they're all connected. I think they're connected neurologically. And I think when you adjust the foot, you're restoring a neural circuit as much as you are.
When you touch the skin, you touch the brain. I mean, it's all. And I mean, some of the fascinating work is of Heidi Havoc, who was a chiropractor based in New Zealand, and she did a lot of work on adjustments and neural perception and resetting of. But it's the neural signals.
No, there's no question. No question.
Yeah, it has to be. And and of course in the books as well, some of the recent students that I was lucky enough to be able to take and mentor some of the students that were coming out for placement here in Ireland, and so the good old spring ligament is in the book there. It makes a good appearance. I mean, I mean, I just thought about that all the time. I mean, surely it's crucial. I mean, these guys haven't a clue what they're, you know, they missed that in anatomy class.
You know, it's funny. If I were to say there's one, you know, it's great how we've quote discovered this importance of the spring ligament, and certainly it's the pivotal ligament with adult acquired flat foot.
He doesn't know where it is, which a lot of newly qualified.
But I think the most important
foot, the medial side of the foot that just runs just under here.
But I think the most important ligament in the human foot is the long plantar ligament.
Yeah.
Because of its critical role in stabilizing the lateral column.
Yeah.
And the humans are the only creatures that have a well-developed long plantar ligament. And without that holding or stabilizing the lateral column, we would not walk with an efficient gait.
Because there'd be too much movement in the midfoot. I mean, that again, the work with Bob and stuff is related to that. That's what differentiates us from the chimps and the gorillas, isn't it?
Absolutely.
So
Absolutely.
that's how you come out of off the ground.
Yeah.
More. And the ligaments are, so the long plantar ligament. Yeah, we're the only ones that have it. You've got to look after it. So you're a fan of mobilization and manual therapies? Then?
Absolutely, very much.
Yeah.
But I don't think it should be all or none. I think one of the problems is it's like everything, you know, if you have a hammer in your hand, the whole world looks like a nail. And I think well-versed practitioners should understand and use joint mobilization, or at least work with colleagues who do, because there's a huge place for it, but it's not the total answer either. So we have to be careful.
Yeah, it's you need multiple tools.
No question.
Depends what's going to work for that particular patient. And so, what's the future bring then? Well, with more understanding then. And well, do you think then we're going to get into a more biomechanics sort of niche, and then somebody way off doing surgery, and things will sort of split? Because again, they're worried about that in the UK here, that the course isn't keeping up, and we're getting undergrad physiotherapists. Here we go. We've got Timothy O'Shea, and then good to see Lawrence Bevan. Don't know what that picture is, Lawrence, but any association between. Can you see that? Hi, Lawrence.
I've not, you know, I'll tell you, I've read a lot about ankle sprains and written a lot, and I have never seen a relationship between flat foot and a propensity to get an ankle sprain. There's some evidence that cavus feet are actually more prone to ankle sprains, but ligamentous laxity and flat foot.
If you sprain your ankle, then you're more likely then to develop flat foot after that?
I don't think so.
GFL, okay.
I will step out on a limb and say there's evidence that, and you know this, the more mobility of the foot, the less likely you are to sprain your ankle. If you have a highly mobile subtalar joint, you are less likely to sprain your ankle, because frontal plane motion of the subtalar joint will dampen and protect the ankle from inversion stress. The more motion you have, really, both in the ankle and subtalar joint, the less likely you are to sprain or tear the anterior talofibular ligament. That's why the essential tool in rehabilitating an ankle sprain is to improve ankle joint dorsiflexion, right? We want to get that talus back in the mortise.
Yeah.
And
shifts forward, and then that and again, but again, more mobility or more in the midfoot. But yeah, so it's definitely more dynamic. It definitely needs to be worked. Yeah, it definitely needs to be worked harder. I would think. I mean, I'm just recovering from my second calf pull playing tennis. Apparently, it's my age. And, no, it's just not doing enough plyometric and eccentric things to be able to shift a dynamic load around a tennis court. And I mean, and again, well, I don't know whether that comes back to the training, that everything's very static and, you know, engineering type of thing, and it isn't really seen as a really dynamic or functioning structure. And it was just, yeah, it's it can take a hell of a lot of use and abuse. without
Yeah.
giving up too much.
Well, like I said, to answer your question, we're on the verge of uh, of like I say, a revolution of understanding of foot structure and function. Now that we have weight-bearing CT and other tools to measure the motion of the bones, and we're getting great insight into the the neural control over the foot. So I think it's an exciting time, and I think the insights are going to be logarithmic in terms of the volume of information and insights we're going to gain in the next 5 to 10 years.
And I think that will be enough time to save. I mean, I'd say just back to the UK, but it sounds as though it's happening in the States then as well. Is that other professions are sort of are claiming a little bit of a march on podiatry?
Well, I think it's because they've studied biomechanics and not confused it with foot orthotic therapy. And I think that was our problem, is everything biomechanics in the States, and I think somewhat in the UK, is you study biomechanics so you can get better results with foot orthotics.
Yeah.
And I think that's a tragic mistake. Because while there is a role for foot orthotic therapy in treating foot pathologies, to limit it to that and say I don't need to understand function of the foot for any reason other than foot orthotic therapy is a huge mistake.
Yeah. Yeah, I mean, my pet theory is the course is taught the wrong way around, and we should teach the 3rd and 4th year biomechanics and everything, so you understand why you're getting the pathology. Because anything, unless you stand on something or have an injury, it's all biomechanics, isn't it? I mean, it's all
really, absolutely.
Even with the complicated diabetic foot as well. And the future of foot orthoses. I mean, just back to one thing you referenced there, what would you be looking for? Of course, it depends on individual, but what would you be incorporating in an orthotic for that type of juvenile hallux valgus?
Well, I'm going to just answer the first part of your question generally. I think it's an exciting time for foot orthotic therapy, because I've always thought that foot orthotics worked in a proprioceptive way, and that they somehow activated muscles and somehow facilitated better neurologic control over the foot. And I think we're going to learn better ways to measure that and better ways to tune orthotics to achieve that outcome. And so I think there's great hope in the future for designing foot orthotics specific to patients who have neurologic, neuromotor deficits that could change the way they function. I mean, it's already happening, but we just don't understand it, right?
Yeah. Again, if anybody remembers, back in the mid 90s, in one of the biomechanics summer schools, there's somebody give a lecture about using textured insoles or for patients, kids with hypertonicity, with cerebral palsy. They showed a video, and they put them on a little sort of textured insole with a little dome and a raise, and it wasn't mechanically correct. The tonicity just dropped out. I mean, it had a hole.
Yeah, and orthotists here in the States have used those for years, and it was never taught in podiatry. But those types of insoles, which actually create an avoidance behavior and retune muscle function, that's been going on for 20 years, but just not taught in podiatry. So,
French and Italian, sort of, when I did some training with the CDAS system in France, which is that sort of, you can make it there and then. Anyway, when they were treating patients in the sports medicine center, it wasn't correction. It was a little bit like that, a little dome underneath the cuboid, a cutout underneath the heel. It was sort of, that's how it made it. There wasn't measuring and calculating angles. It was like his shoulder's doing this and his hips doing, or his neck's doing this. So we're going to put a dome here, and that's going to shift that. And how does that work? Don't know. We'll do some kinesiology tests and get them to run around the pitch again.
And see, that's the problem. Is that's where you begin to lose people. But it might have been that might have been me at that summer school that gave that lecture, because I also did a balance demonstration. I brought in a fellow from TechScan, and we put a mat scan in front of the audience with a screen, and we just monitored single leg stance balance and excursion of center of pressure. And we had them stand barefoot, and then we put various orthotic designs under the foot And it was amazing right in front of your eyes to see the balance improve and the excursion improve.
And I think some of the systems now, even the older foot scan systems, were quite limited in what they could actually sort of show you.
Right.
I think the newer versions there's a lot more combined with center of balance and forces and as well. And again, it used to be just sort of seen to be as a walk on a mat and push a button and off you get you know, the orthotic pops out the other end. So
Right.
again, interesting times for sort of 3D printing or with orthotics and with these scanning techniques.
Well, I think that the 3D part is really exciting because of our ability to really manipulate the prescription to stiffness and torsional stability within the device itself,
Yeah.
which is something, you know, Root even talked about that way back about trying to make the lateral side of the orthotics stiffer than the medial and so forth.
Well, talking about Root, we've got Jeff Root's asking a question now.
Let's see, tendency for inversion and ankle sprains. Yeah, well, you know, more and more, and I talk about this in this the first chapter and second chapter of my book is I'm a big believer in how the forefoot controls the rear foot and how the forefoot influences the rear foot. And McConnell said that. McConnell said this twisted plate arrangement almost mandates that the forefoot's going to control the rear foot because the forefoot plate is wider, has a greater surface area of contact than the heel.
And that was the other thing from the book. I mean, it is the calcaneus is the only other part at the back that's in contact with the ground. All the other joints aren't there, so it's a very small lever there.
And we're the only primate walking on the planet that just walks on the calcaneus. So that narrow little bone and the talus precariously perched on top of it is greatly influenced by the 5 bones distal with a much stronger lever arm, at least in the frontal plane, without question. And that's why the #1 injury in sport today is the ankle sprain, because this precarious talus perched vertically over the calcaneus, the twisted plate, allows that part of that segment to be very vulnerable to frontal plane torque, exerted either proximally or distally. And so to answer Jeff's question, yeah, there is good evidence that cavus feet, particularly those characterized by a plantar flex first ray, impart significant frontal plane instability to this precarious talocalcaneal joint and talocrural joint oriented in the vertical plane.
Yeah. I mean, I've had, I'm sure you have. I mean, I had a patient one time walked about 15 minutes to the tube, and she told me she used to sprain her ankle a lot. I was like, well, how many times? I think she did it 14 times in that 10-minute walk.
Wow.
But it was very, very simple, just like felt forefoot lateral wedge. I mean, she walked out of the clinic and walked around the block and came back in and thought I was a miracle worker.
Yeah.
It's a very, very simple sort of shift of a couple of degrees of position.
Very simple, but very profound. And so, you know,
they're on that knife edge just constantly.
Yeah,
it's quite an extreme example, but
and so, you know, forgetting the forefoot varus, forefoot valgus, and the predictable response of the rear foot, which became a point of criticism of Root. Root did, in a very accurate way, and it was in a tandem way promoted by McConnell, show that a pronated forefoot against the rear foot, a pronated forefoot imparts tremendous stability to the entire foot-ankle complex, and that the supinated forefoot on the rear foot, particularly in mid-stance, is a very unstable situation for the human foot and is, in fact, pathologic. And there's more and more evidence today that all of that is true. So your little...
Is that because the midfoot should be more transitionary sort of?
Well, I mean, what Bojan-Moller said this is that you've got to have a close packed position of the calcaneal cuboid joint. And to have a close packed position there for stability, you have to pronate the forefoot on the rear foot. And when you do that, you're tensioning the long plantar ligament. And so in that 2 sentences, I've just encapsulated what my book and what my own research and understanding is of the critical differentiating feature of the human foot to all other feet. It's the ability to stabilize and stiffen the lateral column.
Yeah.
And the essential motion is pronation of the forefoot on the rear foot.
Yeah, because of course you've got to activate the ligaments and use them to their full extent so that they're going to do their job. I mean, as you said, that's what the pronation comes in and does
Right.
through the midfoot. And so we'll come away from the pathology a little bit, because I'm sure the next book's going to be the treatment of the pathology. Are you going to leave that to somebody else?
I've already had several people ask me. I said, I'm not so sure I'm ready to take that on. I was going to incorporate treatment into this book, and it was so challenging to get through the mechanics part of it. But
what I found was it's very easy to read. I mean, it wasn't very stale. It did sort of flow quite well. So I found it very easy to digest so far. And especially I've only just touched on the heel pain section because especially presenting in most musculoskeletal practices, heel pain is, of course, the most common problem that presents. 50 or 60% of patients are coming in with some type of plantar heel pain. So
yeah, well, I really spent a lot of time on that chapter, and showed all of the different insights into plantar fasciopathy, and I did try to challenge this concept that it's a tensile strain specifically on the fascia, and that there's other mechanisms at play, including shear stress and other factors. But I still think it goes back to the twisted plate, and Serafian showed this so elegantly. I still think it has to do with an aberration of the normal twisting of the forefoot on the rear foot during dynamic gait that goes haywire and places abnormal stress on the plantar aponeurosis, not just tensile stress, but shear stress.
Yeah. But because, of course, some colleagues a few years ago, and this is a question that I asked Bob, would you like your plantar fascia cut, Doug? Treatment. You think that's good? Take that as a no, then.
Yeah. Well, luckily that's fallen out of favor here, but that was quite popular, in the late 90s, and but I think people have somewhat come full circle on that, thankfully.
Yeah. What's the other technique where they do multi sort of holds in it? It's a bit like sort of bone picking.
That was called Topaz.
Yes.
And it was delivering radio frequency current to the fascia to basically traumatize it and initiate a healing cycle, which is, there's other things that do that as well. So it was a way to get around cutting the fascia and had.
They went through the whole phase of PRP with the plasma-rich proteins and different things. I don't know what's on fleek now for treatments.
Well, it's interesting. I wrote an article for Podiatry Today on, quote, new technologies for treating plantar heel pain. And that article had more reads than any article in that magazine last year. It's showing more so because there's so much interest in plantar heel pain.
Yep.
And it was kind of an epiphany for me, because I didn't believe in laser treatment. I thought that was as much witchcraft as joint mobilization was to me 40 years ago, but I came around on that, and I read these studies on laser, and I realized, boy, there's some value here that we need to look at. And there's some studies on laser that are just as compelling as shockwave and PRP.
Yeah, my colleague in London, Gavin, in Streatham in London, he swears by laser. I mean, loves it. Just for ulcers, for non-healing ulcers, for all sorts of things. They just stick a laser on it. Everybody gets better, apparently.
Well, see, there's the problem. And as I tried to point out in my article, whether it's shockwave, PRP, or laser, there's great variability in how that therapy is delivered. The intensity of the treatment, the frequency, the protocols that are surrounding the treatment. And so there's no universal laser treatment that we can all embrace and understand.
and again, it's the whole interaction with the practitioner and the expected outcomes, and there's all sorts of different factors which aren't
Right.
taken a lot of times in research. And well, of course, the shoe industry is interesting then as well, because they're getting into more sort of 3D printed, and from looking at certain talks, a year or two, maybe able to just turn up into a store and have your foot scanned and wait for a coffee, and your 3D shoe is going to be printed with your insole in it already.
Well, early in my career, I worked as a consultant for a sock company, and it was called Thorlo, and the owner and founder of that company was a very progressive thinker, and he had in his mind a way to use socks to enhance shoe fit.
Okay.
In other words, the sock is a gasket between the foot itself and the shoe to fill all the voids inside the shoe to optimize fit.
Mm-hmm.
And we found that there was actually a scanner available 30 years ago to scan the foot 3D to get a better fit. Instead of using this silly Brannick device, which is really just a ruler,
yeah,
we could 3D scan the foot. And we were so excited about this. And we found out that a shoe company in the US called the Brown Shoe Company, was the largest manufacturer of dress shoes, had bought rights to this scanner. And they were going to put it in retail settings.
Okay.
And after they did all this research, they realized they couldn't make it work economically, because while they got all this information about these three-dimensional shape of the foot, they couldn't possibly inventory enough different variable sizes and widths and volume offerings to marry it with the information they got from the scanner, and they let it go. And it's still true today. Shoe retailers can't even stock widths for the human foot, let alone girth.
Yeah, no, I went with my 12-year-old, 11-year-old for his birthday back in September. We went into the shoe store one day afternoon, and he's a size 6 now. He's only 11. They were out of stock in 4 or 5 different pairs. I mean, it's
and that's just one variable. Then you bring the widths in, and for example, New Balance was very innovative 40 years ago to introduce widths for athletic shoes. Well, if the average retailer in the United States doesn't stock all those widths, they can't make it work economically.
Yeah.
And so even that simple system failed for the most part.
Yeah, that's why we used to avoid in our clinics getting into multiple variables of different shoe or off the shelf or preform orthoses and things. You just end up with a whole storeroom full of stuff that.
But I do think with rapid prototype manufacturing, i.e., 3D printing of footwear, may make it economically feasible in the future. I don't know, but I think that is possible. You brought that up earlier, and I think that is an exciting option.
That's what they're moving towards. And then on to sort of shoe design, and again, midfoot. And of course, well, hopefully the Olympics will happen this year. But like I have what's the name of their shoe with a marathon shoe that he did under 2 hours? And I mean, it's very.
I should know that.
No, it's very, very rich. It has this carbon plate supposedly in the.
And I think it's very interesting because that's really looking more, like you say, not just at midfoot, but forefoot, and particularly the first MTP with elastic recoil, which we're understanding is really important for the human foot anyway, as instead of looking at the foot as this, quote, rigid lever, for propulsion. No, it's a spring. And there's a lot of flexibility in the forefoot that we can preload and get this so-called propulsive phase of gait due to elastic recoil of soft tissue, or now the shoe itself provides a lot of that recoil.
I'm sure there was some sprinting shoes, 3 or 4 iterations gone for Olympics that didn't allow the foot to pronate. It had the foot more supinated. Was Michael Johnson running in something that maybe stopped his foot from pronating, and obviously didn't have that?
Well, I'm not so sure.
Obviously, to make the foot more rigid, so he didn't pronate, so he didn't lose time pronating and then resupinating again, so he would have faster sort of foot strike. I must look it up.
I think really the first big innovation was that vapor fly, where they used the shoelacing system and the upper to cinch under the foot, and really, I think, to try to provide more of a spring mechanism through the arch of the, not through the foot, and again, augmenting this load and recoil mechanism through the arch that we're now discovering is really an essential part of just human gait.
Yeah, because you think the majority of sort of whatever torsion bars or anti this or such that they incorporate into shoes actually do anything?
Well, I did. I mean, I saw that early, and when I first went into clinical practice in the early '80s, most of the running shoes, everything was focused towards cushioning. Yeah. And Nike Air came out, but everybody wanted these big pillow cushiony shoes, and my God, we were seeing all these unique injuries. I mean, we were seeing medial tibial stress syndrome far more frequent in the '80s than we do today. And yet they were wearing these over cushioned shoes. And now we know that one of the predisposing risk factors for medial tibial stress syndrome is excessive midfoot mobility as measured by navicular drop. And so this excessive midfoot motion was actually a bad thing in these over cushioned shoes. Yeah. And once we saw people coming in with, quote, roll bars, and Brooks came in with the runner's wedge, I think all it was doing, it was really stiffening the shoe, or taking away some of these excessive cushioning features. So that was my take on it. Yeah,
it's all these things come around. So we've had Hoka as well, and then again the Nike shoes seem to be going sort of that direction as well, and it's interesting. And of course the Richie company started out of that started out of research and development into the orthotics and the bracing.
No, it was like all things. It was kind of an accident. I always, I like you. I had a sports medicine practice early in the '80s, and I would see a lot of athletes with ankle sprains. And back then, the most popular ankle brace was an air stirrup, air cast. And I had a big closet full of air cast braces, and I would slap those on my runners after they sprained their ankle. And I would also put on if they had tendinopathy, whether it's the peroneals or the posterior tib, because it was my only way to, quote, control the ankle. Well, a lot of my athletes had foot orthotics, and they would put their air cast on, and they put their shoe on, and they go, I got to take my orthotic out of the shoe. I can't fit these together. And I would try to have them wear them together, but they wouldn't mesh. The air cast would rub on the heel cup of the orthotic, or it wouldn't get down in the shoe. And early on, I said, there's got to be I could connect a foot orthotic.
Shoe fit is pretty much the one of the biggest considerations you got to take into making an orthotic.
And so I always had this idea, I want to put a foot orthotic on an air cast. And I never got around to it until I saw one in a prototype brace that was off the shelf that had an articulating foot orthotic connected to an air stirrup. And I thought, that's what we need to do. And that kind of evolved into the development of the Richie brace, which, by the way, was just going to be a sports brace. It was just going to be used by athletes to either prevent or recover from an ankle sprain. I never thought it would have widespread use for adult-acquired flat foot or all of the other conditions that it's being used for today.
And then I mean, at what sort of stage do you see that it's good to use that as an intervention then, or when? Because this is always the thing, and then we talked about Bob, and it's a recurring thing with me, and that's back to your hallux rigidus, hallux limitus pathology in the book. I mean, it's always struck me as strange. You end up with somebody with a grade 3 or 4, 10 degrees of dorsiflexion, and they've only had pain for 6 months. How does it get to that such an extreme stage of bony change and dysfunction before they start getting sort of symptoms? And
well, I make a big point of this in the book. There's a complete distinction between hallux limitus, or a functional limitation of motion of the first MTP, or a lack of engagement of it, to hallux rigidus. Hallux rigidus is a degenerative arthritis of the great toe joint. It's a different pathology. It's a different animal. It's osteoarthritis of the great toe.
Yeah, I mean, it is functional hallux limitus is completely different.
And we don't understand why people get arthritis of their great toe. But
because that was interesting, because you do go through the whole sort of parabola, sort of long metatarsals and different things. And again, the research isn't there.
And as I studied functional hallux limitus, the more and more I looked at it, I realized that, I have great respect for Howard Dannenberg, and we've shared the podium many times, and we still communicate. But I just wonder, I wonder why nobody has done a kinematic study to prove that this entity or this condition known as functional hallux limitus actually occurs. Mm-hmm. And I wrote to Craig Payne before I finished my chapter, because I wanted to make sure that I wasn't overlooking it. And I said, Craig, you've written on this subject, you've published on it. Is there a kinematic study that shows that a jamming at the first MTP, a functional limitation of sagittal plane motion, causes a retrograde compensatory chain of events in the midfoot, the ankle, the hip, and the low back in a retrograde fashion, which is how it's described by Dannenberg. And he said, no. He said he had seen Chris Nestor present at a conference some preliminary data that suggested it does occur in some individuals, but it never got published. Mm-hmm. And so the bottom line is, we don't know whether that condition actually exists in some people. And Bojan-Moller never talked about a retrograde dysfunction of the foot. He talked about a dysfunction moving from the lateral column to the medial column to toe off, where a lack of pronation of the forefoot allows or causes a engagement of the low gear push off or push off laterally, which really probably was functional hallux limitus, but it occurred due to a lack of locking or stability of the calcaneocuboid joint, not vice versa.
So which tests then are relevant now then, if you're looking at that, Doug? Do we do Hampshire or do we do Hicks or,
I showed in my book, all of those tests are entirely misleading.
Yeah.
I mean, there's a number of studies showing that you do a test and diagnose functional hallux limitus and then have them walk, and they're using 40 degrees of motion, which is normal. So these static tests are totally misleading and have, I hate to say it, have very little worth.
Well, I think a lot of tests that we're taught, or a lot of tests we look at, and especially if people are, again, pulling out the goniometer and measuring and alignments and things, but it's just a complete waste of time. So, what is that? Just something we pick up with experience over time that can't be sort of taught? You have to teach these theoretical things that may or may not work.
Well, a lot of it is.
If they're there, but I mean, if you do, then if you theorize you have this condition, and then you put in a wedge or a cutout or a cluffy wedge to change position, and they get symptom relief or improve function, how does that work, man?
Well, I think the description of functional hallux limitus should include or really be expanded to basically state that these are patients who are failing to use a high gear push-off.
Yeah.
They are failing to augment and implement all of these unique mechanisms specific to the human foot, specialized to the human foot, that allow us to push off across the great toe joint. And so I think that's really what, quote, functional hallux limitus is.
You can see that on an F scan or a scan, though, can you?
Oh, absolutely. And literally, more and more today, I'm reading these elegant biomechanics studies done, by other specialties, by physical therapy, by orthopedic surgeons and biomechanists, and they're quoting Bojan-Moller all the time now, and they're quoting the high gear push off. Mm-hmm. And they're saying the forefoot should pronate during the terminal stance phase of gait, pronate to engage the windlass and push off through the first MTP. That's all being more and more accepted today. But you're not seeing this discussion of sagittal plane blockade causing this retrograde dysfunction of the entire chain. I mean, that's still, to me, hasn't really been proven, although I don't doubt it exists in some patients.
No. Yeah, I mean, of course, to sum up, I think, well, everybody needs to read the book because it'll definitely change the way they're going to sort of think and look at things. And it will certainly stimulate what you thought you knew. And I mean, I think I've read some of the reviews that you've had in the book already with people who are involved in sort of training and designing of courses, and they're going to already have started to change in one of the New York schools sort of straight away about how he's teaching sort of midfoot, I think he said. So I mean,
yes,
it worked like this that actually sort of ties together everything. And push.
Well, hopefully, and anything stimulates more thought because it doesn't answer all the questions, and it's really not proposing any revolutionary insight. This goes back to 1945 in County Cork, right?
Yeah, that's right. And but again, it was functional hallux limitus. I thought Howard Dannenberg had made that up. I mean, it was somebody back in the 80s. So
exactly. Yeah. But here's the bottom line. I think anatomy, just like mathematics, is a pure science.
Yeah.
And you can't argue with anatomy. It's there. And
I mean, he'll tell you. I mean, it's there. I mean, it's all documented.
I mean, the calcaneo cuboid joint is shaped a certain way in the human foot. Let's study that joint and figure out why it's so unique and how that translates into foot function. And that I kind of took that concept all over the foot to kind of teach foot function, and I think there's great truth and good science behind it. It's nothing revolutionary.
And so we get just back because we skipped over. What tests are then relevant?
So if I were going to write a new,
I mean, I'm sort of having to. I'm going to have a rethink if I ever start getting back hands-on patients. What's relevant and what's not now.
Well, I think if I did write another book, I would go back to diagnostic testing, because I really think a good clinician knows how to not only interview a patient, because getting the subjective information is so critical, and asking the right questions. But I also think diagnostic testing, provocative tests and observational tests are critical. And I don't think that's taught that well. And I did learn a lot in my career of that. I'm a great.
Yeah, especially as you said now with the whether it's changing proprioceptive thing in terms of balance and strength and proprioception.
Absolutely,
we're all getting older, and because that's where when the injuries are going to come, isn't it?
Yes.
So, that's where it's going to be. Yeah. So relevant tests, because there's a lot of tests out there that are just no. They don't tell you anything.
Yeah, absolutely. But
I mean, that is that. I mean, I've always liked that. It is the blend of the science and the art.
Without question.
In terms of treatment. And so where can everybody find out a little bit more about you, Doug? I mean, in the podiatry world, I mean, I think you're pretty well known, but if anybody's listening in and hasn't seen you before, I mean, they can find you at Doug Richie or Richie Technologies.
Well, Richie has a website. It's just richiebrace.com. It's all one word. My name is spelled RICHIE, brace.com.
Yes.
And I'm on LinkedIn, and you can email me. My email is on my LinkedIn profile. You can email me through the Richie Brace website as well. So I love for my colleagues to reach out and give me input on my book or our discussion today or anything. I love interacting with my colleagues.
Sure there's some interesting. Yeah, I'm sure there's some people that have some interesting things to say. Well, especially, I mean, it's good to understand what's happening in different parts of the profession in different parts of the world.
Absolutely.
Normally, what happens in the States sort of follows through here. But of course, that's where the leading I mean, the guys from the London, the South London, the Crystal Palace group went to the States and brought the foot surgery and even just the nail surgery techniques back from the States,
Right.
and push things on. So, you know, it tends to be States driven, but of course the
Yeah.
research is global now. So great, Doug. Thank you very much for being the first interview of the year. Thanks very much, everybody. We'll be we've got somebody else on later on the week, but we'll talk soon. So you hold on, Doug, and we're going to get rid of everybody. And thank you very much, and we will talk soon.